Chaos exists to improve health outcomes for BC, Canada, and the world. Learn more at chaos.ubc.ca.
Okay, so I'm Jeff Cundiff. I've been an investigator at Chaos for 15 years, and I'm also a member of the Department of Obstetrics and Gynecology for UBC and St. Paul's, and have been the head of that department, although no longer. But it's a pleasure for me to welcome you to the Chaos Work in Progress Seminar, virtual edition. And today we will have a presentation by Drs. Sarah Munro and Dr. Tim Teoh. They're going to be talking to us about pregnancy and labor experiences during the COVID-19 pandemic. Sarah is an assistant professor in my department and had the pleasure of hiring her. She's also a scientist at Chaos and is a Michael Smith Foundation for Health Research Scholar, also affiliated with WHRI. Tim Teoh is a clinical instructor in the UBC Department of Family Practice. He grew up in the Lower Mainland and has a wide scope of practice in family medicine, including maternity, and he attends births at several hospitals in the Lower Mainland. And he conducted this research as part of his Clinician Scholars Program. So we'll address questions after the presentation, and if you could please put those in through the chat feature, we'll get to them in that way. Okay, Sarah, Tim?
Thank you for the introduction, Jeff. Really appreciate it. And before we begin, I'd like to acknowledge that today we're presenting, my home office is presenting from the traditional ancestral unceded territory of the Musqueam, Squamish, and Tsleil-Waututh Nations. And if you are interested to follow the Chaos News or Dr. Sarah Munro handle online, we can share more about this particular study and our work after the talk as well. So I'll be handing it over to Tim in a minute, but I'll start with a brief introduction about this particular project. Today, we're going to report on the results of a qualitative study that I supported Tim to conduct, investigating the lived experiences that pregnant people had during the COVID-19 pandemic. And we'll specifically describe how pregnant people adjusted to pandemic restrictions in their daily lives, their healthcare encounters, and their social interactions. But first, I want to tell you a little bit about the Clinician Scholars Program. It may not be familiar to folks on this particular talk. I first became involved as ad hoc faculty a number of years ago, and Tim is a fellow with the program. And perhaps I'll hand it over to you, Tim, to describe what it is and how it supports your research.
Yeah, thanks, Sarah. So as Dr. Cundiff sort of introduced me, I'm a family physician with some interest in maternity and labor and delivery. And coming into practice and even in residency, I had some sort of questions, research questions of my own. And a two-year residency doesn't really give you the tools to create research. And so I started looking into this Clinician Scholar Program, which is a part-time two-year fellowship, which basically starts to give us family doctors sort of the tools and skills that we need to carry on basic research. And this is tools with regards, for example, to creating ethics, writing up manuscripts, but also in the area of networking. So networking with people like Sarah and other sort of, I like to think, top hats in the research industry. And so I found it really, really valuable. I'm about a year and a half into the program, and yeah, so this is my study.
Yeah, and I thought it was a really great idea of something to bring to WIP and showcase some of the work that is being done around COVID-19 and Tim's great leadership in this area. So maybe let's talk about how it started. First, before COVID-19 hit us and we moved into pandemic conditions, Tim's study through our collaboration was going to focus on induction of labor and looking at people's experiences of receiving this care as an outpatient. we were ready to start recruiting. We actually had 3 patients enrolled. Our ethics approved, the funding released from the WHRI Sue Harris grant. And then we all went into research curtailment. And it not only affected our research, but it also impacted how induction of labor was working in our setting. So would our research be relevant given these new restrictions? So for instance, patients received fewer clinic visits, and they had no Entonox or nitrous oxide available to them during labor at the start, and really strict visitor policies. So the question we had was, what next? What do we do? Tim and I had this idea, let's pivot. We had support from our funder to change the research question to focus on COVID-19. And Tim supported this shift by conducting a literature review. Go ahead, Tim.
Yeah. So with all the changes happening during the pandemic to pregnant individuals, the first thing that we kind of looked into is what are the experiences of pregnant individuals in prior pandemics? So if you could just advance the slide. Perfect. Okay. So we did a qualitative systematic review and thematic synthesis. Like a good researcher, I created our PICO question. So this involved pregnant individuals. The intervention was disease outbreaks, and the context was their experiences during these disease outbreaks. I did a search of a couple of major medical databases, and the results of my search yielded 6 studies involving 204 participants from 7 countries, and representing 3 major pandemics and epidemics. So this was SARS, Zika, and H1N1. And currently our manuscript is under review at +1. So the next couple slides are just going to summarize a little bit about my review. And so these are themes that came up, or major themes that came up in this evaluation. The first one was the sense of increased responsibility. So pregnant individuals during these pandemics felt like this heightened responsibility for themselves, for their unborn child, and this was all in the context of a changing world. So lots of responsibility was felt by the participants. The next thing was this idea of hypervigilance, and this is almost this just observing everything, trying to stay on top of the latest information regarding local outbreaks in hospitals nearby, and changes to recommendations. Participants spoke about inconsistencies in the information they were given, and even paucities, like healthcare providers didn't really know what was going on. Overall, though, there was a sense of trust in information sources. So a lot of participants during H1N1 felt that their healthcare providers provided them accurate information. It's just that there wasn't a lot of it, right? Or it was a bit vague at times. Yeah. The other thing was participants' response to risk. So we found that there was this sort of sense of compulsiveness in a participant's response to risk during a pandemic. Things like disinfecting everything, washing hands, wiping down their groceries, using mosquito spray on everything. It was overwhelming. There's also this self-imposed isolation that many participants resorted to despite recommendations coming from healthcare authorities. And some participants spoke about financial burdens. So this was the cost of leaving work early, the cost of buying lots of protective equipment. The next thing was, there was some variability in the sort of perceived severity and susceptibility to infection. So 2 participants during H1N1 thought that maybe that because they were pregnant, that their immune system could fight off the virus a bit better, right? So maybe they were just a bit stronger against fighting this new sort of virus. But then there was also the opposite, right? A participant heard about another pregnant individual who got sick with H1N1, and she thought, well, that makes me really susceptible, right? And that really struck a chord with her. So there's a whole kind of range in people's perceived susceptibility. The next thing was this idea of disrupted expectations. So we saw disrupted expectations across family planning. So people this quote kind of captures it well. You know, I have to plan my reproductive life around the vital cycle of a mosquito, right? It affected childbirth, and it affected postpartum period, and in SARS in Hong Kong. They were restricting the number of visitors in the nursery, so it was tough to even see your baby, and when you did, you had to see your baby with a mask. So a lot of disrupted expectations that happened during that time. So the next question was, you know, we were thinking about how did these experiences from H1N1, SARS, and Zika, how does it compare to the current outbreak?
And so we conducted this review in the spring, and at that same time, that's when researchers were starting to receive funds to conduct research on COVID-19 and pregnancy. There was one early rapid review that was conducted by researchers, including some of our colleagues from the University of Alberta. They looked at 15 studies that were rapidly produced in the early part of the COVID-19 pandemic, involving over 11,000 participants. And they looked at rates of depression and anxiety during pregnancy. We were particularly interested in these studies around mental health and people's experiences of care rather than their clinical outcomes. We were interested in how perceptions of risk might impact how people experience pregnancy. And what these authors found through their review is that depression and anxiety were elevated during the early part of the COVID pandemic. What are the factors that contribute to this trend? What are the things that influence people's experience of depression and anxiety? Well, again, some of these researchers conducted a survey involving almost 2,000 pregnant participants, again, in the early part of the pandemic when most of Canada was under lockdown conditions. And participants expressed concerns over their prenatal care, especially changes to the structure of that care and access to providers. They spoke about their relationships and social isolation. And these things had a significant impact on measures of mental health of pregnant individuals. But these responses were mitigated by social support and regular physical activity. So in preparing for our qualitative study, Tim and my team learned that in past disease outbreaks, pregnant people experienced increased responsibility, and they sometimes engaged in compulsive strategies to mitigate their risk. The pandemic conditions of COVID-19 disrupted their expectations of pregnancy, led to feelings of loss of control. And in Canada, mental health impacts relate to concerns about prenatal care, relationships, and feelings of isolation. And so these understandings help to inform our study, the types of questions we ask, and really get a sense of what pregnancy experiences have been like. And what I want to point out is that what's different from this type of study compared to conducting a survey is we're really able to get a rich, in-depth sense of people's daily lives, their habits, and their experiences. So not just what are their health outcomes, but what are the factors that contribute to those outcomes. So I'll turn it back over to Tim.
So when looking in this qualitative study, we had a series of objectives. The primary objective was just to investigate pregnant individuals' own accounts of their experiences of labor during the pandemic. And then secondarily, we were hoping to see if there were any discrepancies between participants' expectations of labor and then the actual experience during the pandemic. Also to identify factors associated with positive and negative experiences of labor, and then to suggest potential interventions that might improve labor experiences during the pandemic. So like I mentioned, our study was a qualitative, or is a qualitative study. Our approaches are guided by grounded theory. I'm a very novice researcher, but Sarah has been really helpful in sort of introducing me into the whole idea of grounded theory. And this was guided by Shermez, who's written a couple books on this. And in our context, we're looking at sort of focusing the lived experiences of pregnancy during the pandemic, and then trying to link these sort of processes together in the form of a theory. Our inclusion criteria is right there. We recruited on social media. Dr. Munro has a massive Twitter following, so we were able to utilize that. And so that was very helpful. And as well as Chaos also distributed, I believe, a page on their website for this. And so we had some participants recruited that way. Data collection was through virtual interviews. We aim for these interviews to be about 45 to 60 minutes. In our first round of interviews, like I mentioned, because we wanted to compare experiences, we did one in the 3rd trimester and then postpartum to see whether what they thought labor was going to be like was actually true. And then in the 2nd round, we just did one interview and it was done postpartum. In terms of data collection, our interviews started off with a very open-ended question. So tell me about your experiences of pregnancy during the COVID-19 pandemic. And based on people's responses to that, we started to create some structured follow-up questions. And these touched on things like virtual prenatal care, sources of information regarding COVID and being pregnant during COVID, experiences managing risk, and experiences with support and community and the individual's ability to socialize during a pandemic. And we also collected some demographic data, like their parity and age and things like that. In terms of analysis, the next step was to code the transcripts. What that means is after we recorded the audio transcripts, these were transcribed into words, and we would go through them in the process of coding. And so coding is the process of labeling and organizing our data. So looking at participants' phrases in detail and trying to figure out if is there things that are coming up more frequently in the form of themes. For accuracy, Sarah had transcribed a couple of the transcripts that I did. She had coded a couple of the transcripts that I coded, and we compared our codes just to make sure that we were seeing similar themes, right? And in that we discussed these themes, their meanings and their patterns across the different transcripts, and seeing whether we had interpreted them in the same way. And then finally, we developed this master codebook, which we coded all our transcripts with. So here's some results. So we had 17 participants, 11 were in the 3rd trimester, 6 were postpartum, and I did 23 interviews. The median age was 32, 6 of them were multiparous, and the spread of maternity providers is as shown. The next couple slides, I'm just going to briefly summarize our preliminary findings with regards to our key themes.
Perhaps we can go through each of these quickly one by one, and then Tim, I'll turn it back to you to go through what we learned. I wanted to point out how this was a really interesting analysis process, this particular study, as Tim was reflecting on meeting and discussing our coding. Often when we talk about the methods for studies like this, we don't really show you what it looks like behind the scenes. And it was really lovely to kind of have these brainstorming sessions. Basically, we would share our screens, go through what our impressions were of the data, and really get down to the semantics of the language that we were using. Why were we using certain terms, what those words meant, and how they connected back with the words that pregnant people were using in the interviews. And so each of the words here that represent our themes are part of what the participants themselves told us. So that's what a grounded theory, we often want to stay as close as possible to participants' own language. So these words like feeling uncertainty, feeling disconnected, managing risk, these all came from participants themselves. Okay, Tim, I'll let you go on now to the first description of results.
Yeah, so the first sort of common thing we observed was this idea of uncertainty, right? And the pandemic and the response to the pandemic made a lot of our participants uncertain about their pregnancy and day-to-day life, and it was difficult to make decisions regarding their pregnancy in the context of this uncertainty. I should also mention we've chosen some choice kind of phrases or quotes to put underneath. So that was underneath that. So participants expressed a lot of uncertainty about how long these conditions or the disaster response would last, right, and how they would impact their pregnancies. But by and large, a lot of this self-reported stress decreased over time. I'm not exactly sure why. It might be because over time, more providers were seeing these pregnant individuals in the clinic. So that was more reassuring, or perhaps it's because the case counts were going down, or maybe people were just, it was sort of being normalized that we were in a pandemic. But a lot of our participants expressed that, over time, I felt better. The next thing was this idea of feeling disconnected. So participants envisioned a pregnancy surrounded by people, and being socially distanced was isolating, right? And it was tough, right? Their relatives and their friends couldn't visit them, right? Because maybe their social bubbles were too big. A family from out of country, that was perhaps going to provide some postpartum support, and were not able to visit due to the travel restrictions, right? A lot of like the milestones of pregnancy, like, a baby shower or things like that, or a pregnancy announcement, all had to be done over Zoom. This wasn't in keeping with anyone's sort of what they envisioned for their pregnancy before a pandemic, right? So all of these things were changing.
Tim, I'll just add a couple things from the interviews that I was involved in too. I think what was really struck me about people's experiences was how their partners were impacted by it too. Now, we didn't interview pregnant people's partners as part of this study, but their experiences came up as well. So one stuck out to me is the experience of a couple who had had an adverse event with their last pregnancy. A really terrible outcome. And so having a subsequent pregnancy during a pandemic was stressful enough. Added to that, partner was not able to come to the ultrasound. And so not seeing what was happening with that pregnancy, that everything was going well, had an impact on the partner's mental health and well-being. Mm-hmm. Further, that couple actually were able to have a third support person there in labor. So it was the partner and the participant's mother were both able to attend. And they didn't expect that was going to happen, but the impact of that on the person's labor and delivery experience, especially after that adverse event, they described it as monumental. So I think moving forward, thinking about the sort of conditions that are in place, especially around limited support from family and what that means for labor and delivery, it can't be underestimated. The other thing that we heard was around how useless social media was. I know that a lot of programming has been shifted, so there's prenatal education and discussion groups available online for social support, pregnancy and postpartum, but that can't really replicate the sort of connections that are forged in person. And that was a continuous theme amongst participants. Sorry, Tim, continue on.
Yeah, no, that was great. I mean, definitely as a provider, I get this comment a lot that even things like the ultrasounds are going to like other like life labs and things like that. Normally, you could bring your partner in and experience it with your partner, but unfortunately, in the pandemic, you're doing all of it alone. And that's a good kind of segue into the next thing was there's a lot of unexpected changes that are happening with the pregnancy experience. So early on in the pandemic, labor and delivery departments were trying to discharge patients early to reduce their chance of contracting COVID. And so for first-time mothers, especially, early discharge from hospital was not conducive to improving their sort of postpartum experience. For a time, public health nurses weren't kind of checking in on patients in person, and a lot of first-time moms had to learn how to breastfeed over Zoom, where the nurse was kind of trying to demonstrate with a doll, and it's difficult. It made a lot of our participants frustrated. And during that time, it was they were quite vulnerable in that early newborn period. there's a lot of changing hospital protocols. One very common thing is that participants in their kind of second interview or when they were postpartum, a lot of them were glad that they didn't have to wear a mask in labor. That it seems like that was a very big fear of our participants. And the other thing was this idea of prenatal visits being virtual. And this came up a lot, and especially with first-time mothers who didn't know when it was the right time to see a doctor in their pregnancy, or didn't know when to expect feeling the kicks and all that. Doing things over the phone was difficult, right? You go, well, I guess it would be a couple of weeks, up to about 16 weeks without actually being able to hear the heartbeat. And that was distressing for some. In response to these things, though, these changes, a lot of participants took their own steps to monitor the baby. So this included buying scales to weigh themselves, to track their pregnancy weight or track the baby's weight, buying a blood pressure machine. A couple of participants said, I'm doing kick counts a lot more than I think I would, or more often than they should. But in the midst of all this, there's still this trust with the healthcare system. Going in to do NSTs, ultrasounds, they notice everyone wearing personal protective equipment, noticing the physical distancing, and they were reassured, right? And I think that sort of echoes what we found in our literature review from before.
Mm-hmm. An NST is a non-stress test, and it's often done in late pregnancy to check on how the baby is doing as the due date approaches or they go post dates. I think another thing that is really interesting to point out here around noticing the PPE and trusting the healthcare system, it was as participants were actually physically going into the clinic space or the hospital that they started to feel more and more reassured. And that was common amongst people who actually had some face-to-face visits, and it spoke to their sense of being in control and knowing what to expect. And if they had not had those experiences, and participants who really didn't have a lot of encounters physically in the healthcare system, there was that sense of uncertainty.
The next thing was this idea of managing risk. And the way participants managed risks, they did it and it affected their day-to-day life, affected the way they delivered in hospital, and affected sort of the postpartum period. So with their day-to-day life, a lot of participants did similar things that probably we all did, avoiding crowds, not going out in the daytime when there was lots of people about, lots of hand washing, maybe wiping down their groceries, things like that. There was also a bit of talk about things that might prolong one's stay in the hospital. So a couple participants were considering having home births to reduce the risk. One or two participants told me that they wouldn't get an epidural because they were worried that would prolong their labor and prolong their stay in the hospital. So it showed that our participants were thinking actively about how they could reduce their risk in the hospital. And then 3 participants actually made PDF documents of protocols that their family and friends had to follow before they could touch their baby. And so these included, how long they had to quarantine for, the amount of PPE they had to don, and the specific hand washing things involved before they could even meet this newborn.
It's really interesting how the participants created their own tables and protocols for family members. And it, when I was reviewing the data, it reminded me of developing birth plans for healthcare providers. So it really switched who they felt was involved in their care team or in their social circle around care for the baby, and who needed to be involved in understanding what matters most to them and how their safety and their baby's safety could be protected. This is not something that I had ever heard of in my research prior to COVID-19. And it also brings to light a question for healthcare providers. What could your patients be doing in terms of managing their own risk and their perceived risk? And what do healthcare providers need to provide to their patients in terms of evidence-based, consistent information that reflects guidance from the BC CDC. I think I'm going to present the next couple of slides, Tim, is that right? Okay. Another thing that we learned was that with great concern was where participants felt that they did not have control over their social bubble and their environment. So for instance, in the hospital environment, students or people from food services could come in and out of their room, and that gave participants a sense of loss of control over the environment that they were so trying to manage. Another thing that came throughout each of these themes was a sense of what we've called silver linings. All participants shared, without any input from our questions, examples of silver linings where they were experiencing pregnancy during the pandemic. These were expressions of gratitude. These were reflections on their own personal privilege in relation to others and the things that they had access to. So one participant here talks about not being able to have a baby shower, but I guess you have to think of like the positives rather than feeling like you're missing out on stuff. And as a researcher, I always wonder if these sorts of descriptions are the participants' way of sharing with us some positive to balance out the negative of their interview, and there may be some social desirability bias going on, or if these are thoughts that are going through the participant's head on a routine basis. And I think it's important to point out that this is part of the rationalization that patients are going through in thinking of all the things they're missing out on, but also balancing that with a sense of gratitude. So some conclusions from what we've learned from this study so far. Pregnant individuals are experiencing a time of uncertainty and disconnect with their social environment during this pandemic. They're looking for solutions to remain connected with others, with their healthcare teams, to manage their risk and risk to their baby, and to cope with unexpected changes to the way they receive care. And although they feel safe in receiving that care, it's the changes and the changing information, changing protocols that is something you have to cope with. When looking back at our literature reviews and the literature that's been published on COVID to date, there are parallels between our data and the mental health impacts observed in survey-based research. So going back again to the conclusions of the Labelle data from the Pregnancy During the Pandemic survey, our participants also had concerns about their prenatal care, their relationships, and their feelings of isolation. However, it was unclear how social support was really making a difference in their lives because they felt that they did not have adequate social support, either in labor or in connecting with their family and friends. Regular physical activity was not something that we spoke of routinely through the interviews. Perhaps, Tim, do you have any thoughts on how physical activity played into this?
No, it wasn't brought up.
Yeah. So that's interesting to note that in terms of self-report, physical activity was not something that our participants engaged in to mitigate their mental health concerns. So some of the strengths of our study I'd love to point out include this really rigorous grounded theory approach that Tim took. He took the time to learn this method and to really apply it. He also used theoretical sampling. So as he was conducting interviews, he would learn about what's happening in this phenomenon and then follow up and recruit people and ask questions that helped him to better understand this emerging theory. We have a longer study period than many of the studies that have been published to date. The fact that we've been collecting data up until the end of 2020, it helps us to see how perspectives have changed over time in response to changing protocols and changes with, say, hope for the vaccine, how that's impacting people's attitudes. I would say that one of the silver linings I didn't report on above was that people see a bit of a light at the end of the tunnel and hope that once vaccines are available, that their postpartum experiences will go back to normal. I've already mentioned the potential for response bias, particularly around that theme of silver linings. And a note around adaptability. So this is a small qualitative study, and the aim of a study like this is to understand some in-depth data about what's happening with the phenomenon. And so the adaptability of this is going to be relevant for similar populations in a similar healthcare setting. I'd say other pregnancy populations where average age is 32 across BC. The findings may be adaptable. And they also can provide a starting point for other researchers who are interested in this topic to go and develop surveys or to look in depth at administrative data as it emerges, and really focus in on some of the key things that participants have talked about. One of the aims of this work was also to identify some potential interventions that could improve pregnancy and labor experiences. So first and foremost, in response to participants' concerns about information, there really is a need for some way to develop better patient-facing, clear and consistent information that's updated as protocols change, that's updated in response to local changes. So this can reduce uncertainty and really provide clear expectations for what birth may look like, not just for primiparous patients for whom this is their first birth, but also for multips who already have gone through an experience and have that anchor, that experience to look back on. In-person social support is something that we should be exploring. How can we provide the conditions for pregnant people to have social support through prenatal classes and meetups, for well baby care postpartum, and to do that in a way that is still within pandemic restrictions. It's something that has, from the perspective of participants, had a huge impact on their well-being and their experience of pregnancy. And so we should be listening to that and thinking of strategies and recommendations that could help to fill that gap. And then finally, not recently, this is the joint statement here that I'm citing at the bottom on support persons in labor. There is a clear need for increased support for the labor and delivery experience. Having one person alone in a labor and delivery room is not enough for many people, especially for those impacted by stigma and trauma and violence. And when people need to have a cesarean section, our understanding is that fewer people are allowed in the operating room. A partner may not be permitted. And so there's the potential for anesthetists to really support doing patient-centered practices like skin-to-skin care post-cesarean and finding safe ways for partners or another support person to be there in the operating room. And finally, to sum this up, I love the updated committee opinion led by our colleague Chelsea Elwood on COVID-19 and pregnancy. This was just reaffirmed last month. Expectations about pregnancy and infant care should be individualized to each maternal condition and each family's values. So again, coming back to patient-centered care, it really depends on each patient. And what we learned through the interviews is each person had different things that were coming up for them as key factors that influence their experience. And so I think Tim is going to speak a bit to that and how this work has impacted his practice and approach to patient-centered care.
Yeah, so I mean, as a kind of novice researcher, conducting my first set of qualitative interviews, there was sort of this, I ran into a couple things where I had to make sure that participants felt comfortable in their interview space. I had two participants who actually did their interview in their minivans in their garages, so their kids can bother them and stuff like that. So just making sure there was sort of a safe and space for my participants to interview in was important. And then in terms of my sort of practice takeaways, the results of the study definitely changed my practice. You know, immediately off the bat, I was seeing there were a lot that I was seeing the impact of virtual prenatal care. So, and even as sort of a new clinician, doing things over the phone also created a lot of worry as well. So I definitely prioritized the uptake of PPE in my clinic and seeing patients in person throughout the pregnancy. And I found that my patients responded quite positively to that. And definitely, as Sarah mentioned, a lot of sort of the psychological and mental health things related to the pandemic, and that came up in my research as well. And so I found myself checking in or doing a more thorough check-in on mood throughout my prenatal visits as we kind of moved into the period of February last year and as the numbers started rising. And so I definitely checked in with the mood a bit more during my visits.
And that brings us to the end of our presentation. This is work in progress, and we are going to be preparing our publication from this, and as it works in with Tim's busy schedule, and finding other opportunities to present this work. So I'd love to hand it back over to Dr. Cundiff to facilitate discussion. And if you have any questions, please enter them in the chat. And thank you very much to CHAOSS for the opportunity to present, and Tim for the opportunity to mentor your project.
Thank you.